Vaginismus, sometimes called vaginism, is a condition that affects a woman's ability to engage in vaginal penetration, including sexual intercourse, manual penetration, insertion of tampons or menstrual cups, and the penetration involved in gynecological examinations, pap tests. This is the result of an involuntary vaginal muscle spasm, which makes any kind of vaginal penetration painful or impossible. While there is a lack of evidence to definitively identify which muscle is responsible for the spasm, the pubococcygeus muscle, sometimes referred to as the PC muscle, is most often suggested. Other muscles such as the levator, bulbocavernosus, circumvaginal, and perivaginal muscles have also been suggested. 1. A woman with vaginismus does not consciously control the spasm. The vaginismic reflex can be compared to the response of the eye shutting when an object comes towards it. The severity of vaginismus, as well as the pain during penetration, including sexual penetration, varies from woman to woman. Primary vaginismus. A few of the main factors that may contribute to primary vaginismus include a condition called vulvar vestibulitis syndrome, more or less synonymous with focal vaginitis, a so-called subclinical inflammation, in which no pain is perceived until some form of penetration is attempted. Urinary tract infections. Vaginal yeast infections. Sexual abuse, rape, other sexual assault, or attempted sexual abuse or assault. Knowledge of, or witnessing, sexual or physical abuse of others, without being personally abused. Domestic violence or similar conflict in the early home environment. Fear of pain associated with penetration, particularly the popular misconception of breaking the hymen upon the first attempt at penetration, or the idea that vaginal penetration will inevitably hurt the first time it occurs. Chronic pain conditions and harm avoidance behavior. 4. Any physically invasive trauma, not necessarily involving or even near the genitals. Generalized anxiety. Stress. Negative emotional reaction towards sexual stimulation, for example, discussed both at a deliberate level and also at a more implicit level. 5. Strict conservative moral education, which also can elicit negative emotion. Secondary vaginismus. Further factors that may contribute to either secondary or primary vaginismus include fear of losing control, not trusting one's partner, self-consciousness about body image, sexual abuse, rape, other sexual assault, or attempted sexual abuse or assault. Misconceptions about sex or unattainable standards for sex from exaggerated sexual materials, such as pornography or abstinence. Fear of vagina not being wide or deep enough, fear of partner's penis being too large. Undiscovered or denied sexuality, specifically, being asexual or a lesbian. Undiscovered or denied feelings of being Treatment. Psychological. According to Ward and Ogden's qualitative study on the experience of vaginismus, 1994, the three most common contributing factors to vaginismus are fear of painful sex, the belief that sex is wrong or shameful, often the case with patients who had a strict religious upbringing, and traumatic early childhood experiences, not necessarily sexual in nature. People with vaginismus are twice as likely to have a history of childhood sexual interference and held less positive attitudes about their sexuality, whereas no correlation was noted for lack of sexual knowledge or non-sexual, physical. Treatment. Physical. Often, when faced with a person experiencing painful intercourse, a gynecologist will recommend Kegel exercises and provide some additional lubricants. Strengthening the muscles that unconsciously tighten during vaginismus may be extremely counterintuitive for some people. Also, vaginismus has not been shown to affect a person's ability to produce lubrication, thus providing lubricants may be extraneous to the actual condition. Treatment of vaginismus may involve the use of dilators, sometimes called vaginal trainers, progressively increasing the size of the dilator inserted into the vagina.